Good morning, and welcome to peripheral.interventions.org. This is Dr. Jose Wiley transmitting live from Mount Sinai Medical Center in New York City. Today is May 21st, 8 o'clock in the morning, Eastern Standard Time, and I welcome you to this interesting live case. You may post your questions at info@peripheral.interventions.org, info@peripheral.interventions.org, and I'll be happy to relay the questions to Dr. Krishnan. I will remind you that the live symposium of complex coronary, valvular, and vascular cases will be held here at Mount Sinai on June 10th to 13th. Good morning, Dr. Krishnan. What do you have for us today?
Good morning, Dr. Wiley. Nice to see you. Thank you for the kind introduction. And again, to the audience, to reiterate what Dr. Wiley said, our live peripheral intervention cases will be on the website, but as well, our complex coronary and vascular symposium is around the corner on June 10th, 11th, 12th, and 13th. I'd like to welcome you to Cath Lab 6 here at Mount Sinai. Our team, as always, is Dr. Karthik Guja, our outstanding endovascular fellow, Dr. Ray Lascano, our MP. We have Ricardo, our tech, and our nurse is Elizabeth Holton and Mary Chu, who's not here yet. We have a wonderful case demonstration here. I'm going to let Karthik start off with the presentation.
Can I have the slides on, please? Thank you. The first one before. Thank you. So good morning, everyone. So we have a 80-year-old female patient who came in with complaints of bilateral claudication in the calf, right much worse than the left. And she's Rutherford class 1, category 3, I would say. Actually, she has wrist claudication, so she's almost close to 2. She has a past medically significant for hypertension, dyslipidemia, diabetes type 2, COPD, and cardiomyopathy, non-ischemic cardiomyopathy. So she's on Zocor, lisinopril, Pratec, aspirin, Plavix, Norvasc, and albuterol. She couldn't be on beta blockers because of her severe COPD. She's a 40-pack history of smoking, alcohol, IV drug use. Next slide, please. Her vital signs are pretty stable, as we see here, and she has Doppler pulses on both sides, DP and PT bilaterally. She had imaging done outside. The workup done was ABI PVR, which showed 0.7 on the right. This is resting, and 0.82 on the left, with the waveform suggestive of femeropopliteal disease. Her peripheral angiogram, which was performed here, showed chronic total occlusion of the ostial right SFA. She has one vessel runoff of the right lower extremity with the peroneal, which reconstitutes both right 8 DP, distal AT, distal PT in the foot. And she has CTO of both proximal right AD and PT. She has borderline stenosis of the left common iliac and significant stenosis of the left SFA and the left peroneal, with the CTO on the left AT. As you know, she's a vasculopath. And then we attempted it, an attempt was made antegrade from above with crossover for the CTO of the right SFA, but it's an ostial calcified, moderately calcified occlusion. As Dr. Krishnan is going to show it to you, and we have decided to go retrograde here. So the plan here is to go endovascular intervention of the ostial right SFA with retrograde access.
So, Dr. Wiley, thank you so much, Dr. Guja, for that presentation. As you can see the angiogram here, so let me tell you the setup. So as Dr. Guja said, we had an attempt from above. So clearly you can see we decided to go retrograde for multiple reasons. First and foremost, for all of you at home, how we're going to do a retrograde access, there's multiple different ways of doing it. You can get popliteal access, you can get obviously access from the tibial vessels, but in this particular lady, she has single vessel runoff with occluded AT and PT, which precluded that to do it. So we decided to get popliteal access, and we went through one of the many methods in which you can do it. This one we decided to obviously lay the lady on her stomach, got radial access, went up and over, put a pigtail catheter at the level of the external iliac or common iliac, and then did some diagnostic angiography. So as you can see here, she has a flush occlusion of her SFA. As you can see, there's absolutely no stump and really very difficult, kind of a smooth border in which the catheter kept deflecting off into the profunda when we attempted it. And then at the same time, she has single vessel runoff, as you can see, via the peroneal artery to the foot. So at this stage, what we decided to do, what we decided to do here is show you the access points and what you can do. So there's multiple different ways. We can see we have an echo machine. We went ahead and did an ultrasound of the popliteal artery to see exactly where the vein and the artery lie. In this case, they were lying side by side. You can get Doppler guided popliteal artery access, which I think is phenomenal because you avoid entering into the vein. But in this case, for lack of time, we decided to show you angiographic evidence of how to do it. I think first and foremost, it's very important that you get multiple views of the popliteal artery and pick a relatively healthy segment to enter. So you can see the proximal pop or the SFA in the adductor canal has a stenosis, and then as the popliteal enters into the above knee popliteal, you've got some mild moderate disease. Second thing, what you want to do is we use the smallest needle possible. We use the micropuncture needle, and for demonstration purposes, we showed you multiple different views. So here's one view where we took, and I believe this is like a straight AP or a slight LAO. You can see we're almost on top of the artery. Then what we did was we did an LAO cranial view or a more profound LAO, just to make sure that you're looking at this artery in 3 different dimensions. And you can see right there, you seem to be right on the side of it. And remember what I said, the vein is lying to the side of the artery, so you got to be extremely careful. And then this is another view, which is an arterial view, to again clearly show that you are in 3 different planes, pretty much close to the popliteal. So at this stage, what we did was, I don't think we cined it, or maybe we did, we actually entered the popliteal, okay, with a little dye to show that we're entering the vessel, and we used a stiff micropuncture wire to advance up. Then what we've done for our setup here is put a micropuncture sheath, and I'm planning on getting started with the intervention.
Dr. Christian, now in most instances, the popliteal artery sits posterior to the popliteal vein, and angiographically we have a 3-dimensional object that we see in 2 dimensions, so sometimes it's difficult to get access angiographically. When would you use ultrasound guided approach versus angiographic approach?
You know, Dr. Wiley, I firmly believe that you're going to use ultrasound guided access when you're getting the 5 French, please. When you're going to get access at the level of the popliteal fossa. As you know, the vein and the arteries relationships change as you go from proximal to distal. So what we decided to do, I never get access directly in the fossa. I get it just proximal to. And we've done this multiple times without a problem. And I think it's a little bit of experience that we do. Obviously, Dr. Guj is very well versed in ultrasound and may do that. You and I, for the most part, don't use ultrasound, but however, we have used ultrasound when needed. So I really think that it depends on where you're getting access in order to do this. So the key is once you have your access, you want to go ahead and introduce a 5 French sheath, which is what we're doing here, with a little bit of, obviously, pain that the patient is going to experience. Hopefully, this may go through, and it's not. So I'm going to have to make a little nick. So what I'm going to do is, the dilator came back. That's what happened. Okay, and the sheath is messed up. Give me another sheath, guys. So the key is now you want to put a short 5 French sheath in, and your anticoagulation is basically right now is going to be on heparin. So the reason we chose heparin over bivalrudin in this particular case is so. Did you get a new sheath? Yeah. Okay, so that we can always reverse the anticoagulation in case for whatever complications can occur in the access site at the popliteal, which we really don't anticipate that from occurring. Generally, show me down, please. Generally, you don't want to lose wire access you don't want to use wire position getting access. For some reason, we're having a lot of trouble with this wire here.
So what wire do you have there?
We have a super core, but let me see below. Okay, give me a dilator, guys. So I'm going to have to dilate this. So these are the type of problems you may encounter. I mean, the problem you may encounter is actually entering the skin, because obviously it's a very taut skin at the level of the knee joint, and these are things that you have to prepare for. So the key here is to get in with your sheath, and then the plan has to be is to cross this lesion, and there are multiple challenges that I want to talk to you about. The first challenge that we want to talk about. One second. I'm just trying to get this wire up further here since we're having a lot of trouble here. I'm just going to throw it up there. The first challenge that we're going to deal with.
I don't think you have a rail with the wire.
Well, the problem is it's a super core, which is quite a stiff wire. So now what we're going to do is we're going to come out after I dilated the track. Now we're going to go back in with the sheath. and see whether this is able to get through. But the problems you've got to anticipate is, first of all, traversing the lesion, which is always an issue. Second is when you have a flush aorto-ostial lesion like this, you don't want to extend the dissection plane too far into the common femoral. So you have to be extremely careful as you're going above into the common femoral to really try to enter properly in the common femoral. So here what we're going to do is we're going to, hopefully this sheath will now go in, and it does. So lo siento, mama. So it did go in. So now we got the sheath in. Now I'm going to ask Elizabeth, our ACT here. So our ACT is therapeutic, so we know we're not going to clot off the popliteal at this stage. So now what we're going to do is we're going to go with the standard technique. You can use multiple techniques. You can use a Viance catheter from below. You can use a standard wire from below. And I think what we're going to do is first put a steerable catheter into the SFA, and then we're going to decide what we're going to do. The advantage of the Viance catheter here is that it may just go straight in and pop in. For those of you who don't know what a Viance catheter is, it's a catheter that basically finds fenestrations within the vessel and tries to find the true lumen rather than the dissection plane. So in this particular stage, what I may decide to do is just go with the Viance catheter. I'm going to let Dr. Guja flush this first to prevent any clot formation within the sheath, which I think is incredibly important, obviously.
But you're going in right now with a vert tip catheter? Or?
With a vert tip catheter over a supercore wire for the time being.
Okay.
So here goes the vert tip catheter. Now it's important to use a catheter that has a marker, right? So we're going to stop here for a second. We're going to use a catheter that has a marker. And then what we're going to do is we're going to see how this wire goes. So what I'm going to do is I'm going to ask Dr. Guja to give a little dive from above. Hold on, let me get in the right camera angle. And it's important for the team that's watching at home to understand is you're working in the opposite of everything that you've done before, right? So here, we're just going to go ahead and get the tip of the wire and then get the tip of your common femoral kind of in the same picture. And we're just going to give a little DSA picture to see this. Inject. So it's pretty attractive in the track that we're going. Wouldn't you agree, Dr. Wiley?
Yeah, I think so. Okay,
the other thing also we'd like to do is take a picture below to make sure we didn't get into any collaterals, right? So we're going to inject here. So you can see here when you inject, you can see the reconstitution of the SFA/pop right about there, right? There you can see it, right? And, well, barely see it. And then you can see that now you're actually in the right track. So what I'm going to do here is ask Dr. Guja to just rail my wire. And I'm just going to ask him to advance the wire slowly and see where this wire takes us.
But you're going to exchange that wire?
No, I'm just going to see how.
Keep going?
I'm just going to see how. Don't push too much. See, the key is here. You can't get too eager and push. So what you want to do is just kind of see where the wire is going, because I've never had a problem necessarily switching from a 035 to an 01, because the plaque generally, when you go retrograde, is a lot easier than when you go proximal. So this seems to be where the real issue is occurring, which is right about here. And as you know, most SFAs are not necessarily totally occluded. What's happening is that you're having maybe some focal spots of occlusion, followed by some areas of what can you say, thrombus. Little dive, please.
Yeah, I think we could all attest that the distal cap is usually softer than the proximal cap.
Okay, so you see, we're sort of in a very strange zone here. So I'm going to pull out this wire here, and this may be the area where you want to introduce the Viance catheter, or do you want to go with the wire? And I'm going to leave it to our team to decide whether they want to go with a Viance or a wire. Dr. Wiley?
I think it's attractive to use the Viance at this stage.
Okay, so let's try the Viance catheter. So we're going to try the Viance catheter to see whether or not this goes in. So this is a support catheter. This is a CTO crossing catheter, which is going to allow you to be able to hopefully find the right channel and then enter in the common femoral where you think it should.
I mean, we're hoping that we're interluminal stage.
You would think that you would not be dissecting with that particular type of wire that we were using, right? I mean, but in all likelihood, we're probably not dissecting in that situation. So therefore, I'm pretty confident that we haven't dissected the plane here. So what we're going to do is now go ahead and introduce the Viance catheter in. And what you want to do here is to use a stiff wire to allow you to give yourself some support. So Dr. Guja is going to take it out to the level of the proximal end of this. There it is, right about there. And now what he's going to do is go ahead and put the CTO wire, which is in this case is a Confianza Pro stiff wire in this area.
So we're changing from a 035 inch to a 0.14-inch system?
Well, the 0.14 system here is going to allow you to be able to direct this Viance catheter, because it's a smaller gauge catheter, to be able to enter. And likelihood is not going to create a massive dissection plane that you're going to have to deal with. Again, the key point of this entire case is to understand that you want to be able to enter this at the level of the common femoral, hopefully in a nice manner. Now, Dr. Guj has become an expert at this stuff, and what he's going to do is he's going to go ahead and show. Can you focus on his hands, please? He's going to show how he does it. And again, it's very slow. It's not much positive pressure. It's allowing the catheter to find its way. As you can see, I'm not even going to move here. I'm just going to let the catheter go. And you can see here the catheter is moving extremely slow and extremely beautiful.
It hasn't clicked yet, right?
It hasn't clicked yet, which is important, because that's a great point, Dr. Wiley. That clicking tells you that you may be in a subintimal plane. So right now, we're going to keep going up, right? I'm not even going to advance. Oh, lo siento, mama, no te mueva. So you can see, slow down there, please. Now what we're going to do is we need to really see the proximal cap, because this is where you can get off plane and you know, the case can get spoiled. You can see the significant calcium there, Dr. Wiley, which is going to give us an issue here, and I promise you that. So part of the planning that the group has to do at home is to really decide, well, how far are you going to advance this, and when are you going to use a different type of re-entry device at the level of the common femoral. So right now I'm going to have Dr. Guja rail me.
Now you have a catheter sitting in the aortic bifurcation, correct? From a radial
I am going to advance this catheter now from below to give Dr. Guja a little bit more support, right? Now what I'm going to do is I'm going to give him roadmap to allow him to know where he's going. Actually, I should actually go a little bit higher, pardon me. I'm just going to go a little bit higher for him, right there. And then with the roadmap, we should be able to see exactly where we're going. Now, you know, listen, it looks a little off to me, but let's see. You know, like I said, let's see. So what I want to do is just see how this catheter behaves. Let Dr. Guja twirl it a little bit. Okay, it's starting to straighten out there, which I'm pretty happy
good to
with.
me.
Okay, now stop there, please. So now what I'm going to do is advance this catheter to Dr. Guja. And now I'm going to kind of torque it away to where I think the SFA should be. And then I'm going to advance the Viance. Okay. Okay, now I'm going to ask Dr. Guja to slowly, no. Slowly advance the wire. Okay. No, you're not in. Pull back, please. Okay, now is when the trick comes in. Let me get a feel. Now is when the trick is going to come in.
Well, I think the patient moves, so I'm not sure how valid is that.
Well, remember, you don't really need anything here other than catheter and wire movement here. Because once the wire is in, you know, you're going to know. Now, a lot of times, as you know, Jose, when the patient moves, it becomes much more difficult for you to really see where you're at. And the question becomes is, see, we're definitely not there. So can I get another wire here, guys? Can I get a Confianza, not a Confianza, a Fielder type wire here? Don't advance, please. Nope. So what I'm going to do here is probably take out the Viance catheter, because we got it to where we need to go. ¿Qué pasa, señora? Okay, can somebody see what you... She's fine. Oh, you're moving her. Okay, gotcha.
So the question is, if you have entered a dissection plane from below, at the level of the mid portion of the SFA, or if you're not, are you confident you're in the right track?
I know I'm pretty close. I know I'm pretty close here. You know, I think that, you know, you can see that we're in the right view. We kind of see where the SFA is. You know, I doubt we have poked into the vein by anything or any collateral at this level. And this is what I'm talking about, actually having that sense and that feel to know where you are, and also understanding why this may be failing is the level of calcium that we're dealing with at the ostium of the SFA. So you can see here, I'm just going to come, and you can see there's our see the calcium it's hitting there, Dr. Wiley?
Yep.
See, that's the plane that the Viance created. So this is the calcium that we need to get into. So give me back the Confianza, guys.
Will you consider a 035 angle glide catheter?
I am. I'm just going to be delicate here for a little bit, and then I'm going to decide what to do in a second, and I may go with a straight glide. But remember, the whole point here is not to extend the dissection plane into the common femoral if we can. If we can get side by side, we can use a re-entry device at the level of the common femoral and then get in. That's going to be the point here. So what we realize here, Dr. Gujo and myself, is that when we use these 0 and 4 wires in these kind of delicate situations, it buys us a little bit of time to, first of all, understand what the plaque is behaving like. And then secondly, it also lets us know that, well, how far up the dissection plane has really, traveled. So here, the calcification has really hurt us here. So now we're going to just try to see whether we can, break through the calcium, although this is definitely subintimal here, Dr. Wiley.
Yeah.
As you can see, we're having quite a bit of trouble here, which is what we expected, really. And that's why nobody could cross this from above. So the issue just becomes there it goes. Now let me just give a little dive from above. So, a lot of times, like I said, a little delicate entry. Oh, she's moving. Is she okay, Liz? So it's a little bit in a different type of plane, Jose, as you can see. So what I'm going to do here is pull it back a little bit and redirect it if I can. And it seems to want to go in that plane. There you go. And we're still not through. We're close. Another plane there, traveling along the side of the vessel, as you can see, which may be what we're going to have to use to get back into the vessel. Nope. Now remember, you're in a 3D vessel in a 2D view, so it's very difficult for you to get a feel of where you are.
Correct.
So a lot of times what you may have to do is really go more by feel than anything. And I'm just going to try to point it in a different direction, and it just seems to want to find the same plane. I like this plane a little bit better because it's taking me away from. I could feel the calcium. It's just bouncing off that calcific plane on me, and really not allowing me to find the true channel there. And we have really anticipated this as quite a challenging live case to take on, really. But Dr. Gujo and myself really felt that, are we nuts in choosing this?
Promising. You maybe a little anterior.
Actually dissecting, I can see the wires now flipping, Jose. And I think that's what people have to understand is you have to really know the behavior of your wire to really decide. Give me a V18 wire here, guys.
I think a 035 glide, and if you're able to make a loop, it may go right in.
Yeah, but you have to be careful, I think, here with the 035 glide, because I really think that, see, this is just dissecting up the common femoral. See the wire's not moving at all? And I think that's the important thing. So let's try a V18 here, and then we'll go with the re-entry catheter. So when you use re-entry catheters here, obviously you don't know which side you're really going to enter in. So one of the things we may want to use is a Pioneer catheter, which may be able to help you get with ultrasound guidance where you're going, or you can use a Outback. So we'll see what we're going to decide. Or you can even use what's called as a anterior. So we may do one or the other. Let me see what we're going to do here. So you can see that I'm using the catheter to point away from the plane that I want to go right there. I want to go in that direction. Ooh, that was a little harsh. Sorry, guys.
That wasn't delicate.
That was not delicate. That was anything but delicate, Dr. Wiley. I'm going to ask Karthik to advance a little bit here. Okay. See, again, it's deviating into that plane that Dr. Gujo was in before with the anterior. Anterior again. I think we're going to have to try something with the Viance. See, now that's just dissecting.
What view do you have right now, angiographically?
Well, we're in the LAO, the ipsilateral 20 and 30 view really is what we're doing. Advanced catheter, Karthik. Okay. No. I don't know if we're in.
Does the V18 wire?
Yeah. No, we're not in. Nope. All right, so we're gonna have to switch back to a confianza. We're gonna get the anterior. Give me a mailman and anterior, guys. Actually, Grand Slam and an anterior. And this is the confianza again.
No, that's not.
Oh, okay. We're going to try again with the confianza and one other view. So part of that is the struggle that we're all going to face in these kind of lesions, which is going to make it a little bit more difficult, as we know. So notice we did not upgrade our sheath till we succeeded. So right now we have really good access control with a 5 French, and we're not going to upgrade our sheath at this level, at this point. I like that channel, and you know, this is the point of where you get multiple wires and multiple channels to be able to try to get through.
Dr. Krishnan or Dr. Guja, do you mind explaining us how that catheter works? We all know that Pioneer is ultrasound-guided re-entry devices.
So Pioneer is an ultrasound-guided re-entry device. The problem from the popliteal will be it needs a 7 French.
I'm through. See that? See that, guys?
That's it.
Okay, now you got to worry. Okay, I'll tell you why. See, now what I'm going to do is walk this out and do an IVUS. Why I'm going to do an IVUS here is I want to see where I entered in the plane in the common femoral. Now, I don't know, you know, studying the common femoral is not our favorite practice, and so the point here is that since we're through at this level, the question is, are we through properly, or are we not? So you know what? I'm just going to pull this catheter back with Dr. Guja's help, you know, and we're just going to do a quick IVUS to demonstrate where we are. Can you walk the catheter out without losing the wires, Karthik? So the key here is...
So you use no re-entry device at this time?
We did not. So we just went ahead, and I'm just going to have Dr. Guja very delicately... Remember, you can't advance this wire because you could go up into the internal iliac and cause issues, right? So what you want to do is really gently, you can watch the tip of the wire if you'd like. Obviously, I trust Dr. Guja. Lo siento, mama. You can see, we trust Dr. Guja implicitly. So, you know, the wire, as you can see, it's in the circumflex right there, which can cause issues, which is fine. But you got to be careful that you're not advancing that into the circumflex, because then you can cause what's called, as you know, is a rectus sheath hematoma. So right now, it's very important not to perforate anything, because you don't have control from above, you're working from below. So at this stage, now that we're across this lesion, we know the wires in the circumflex iliac, which again is heartening for us, knowing that it's in a vessel that we know is a true named vessel. And now we're going to go ahead and do an IVUS to see how we entered into the true lumen and really study the vessel a little bit better. We're going to do a manual. Pull your fluoro, please. I'm just going to try to see whether I can place this in a better area, just to make myself a little bit happier. There we go. See, now I'm a little bit happier. You know, I'm not in a situation where I'm going to worry. Lo siento, mama. Where I'm not going to worry too much about this. So Dr. Guja is going to keep the tip of the wire in the screen, not allowing it to go forward. Show me above, guys. Okay, there's the tip of the wire. And now I'm just going to advance the IVUS catheter. Show me below, guys, now. Now that I have control of both, I can come down and show me below. And what I'm going to do is just take the IVUS catheter.
Are we going to see the IVUS images?
You are.
There you go.
So here's the proximal cap. So you can see we're really intraluminal here, don't you?
Yeah.
And then what we're going to see is fluoro. We're going to advance it through the calcific cap here. And there's the true vessel. So what I'm going to do is I'm going to ask them to put ChromoFlow on. Chromo, guys.
Chromo on, guys.
Okay. Good. Now you can see that's the profunda SFA there. I'm going to give some dye from above. Okay, so you see how far up we are, and we're just going to pull it back. You can see there's a little bit of a plaque, a little bit of a dissection, but nothing too crazy. And there's, see right there, a little dye now?
That's your bifurcation.
That's your bifurcation. Still not in the bifurcation, no dissection there. And now at this level is where I'm looking for dissection. There's our re-entry point there with really no dissection. You see that? See that, Dr. White? A little dissection there. See. But not horrible.
Yeah, but that's actually in the ostium of the SFA, right. So we're okay.
So we're okay here. So what we're going to do is now we're going to go ahead and put our aqua tempo back in, and we're going to enter into the common femoral. So we're putting our 4 French vert tip catheter and entering into the common femoral, and then we're going to upgrade our sheath and decide what we're going to do.
So
again,
you're going to intervene from the popliteal. You're not going to get access from the other side.
That's an incredibly good point. One of the things that we could talk about, maybe Dr. Guja could mention this, is the two different techniques after access. Karthik, can you talk a little bit about that?
So one is you can stent from below if you have to. We have decided to stent this vessel because of the amount of calcium there is. So we went in thinking that we were going to stent this vessel. And it can be done on a 6 French. And this vessel is the popliteal was based on the ultrasound, as we did before, was like a 6-0 vessel. So which is we're comfortable putting a 6 French sheath. The other way of doing it is put a 4 French. We could have gone with a 4 French, cross the lesion, and then go from antegrade axis from the other side, crossover.
But you got to flip the patient.
You have to flip the patient. So there are 2 ways of doing it. When you want to do it that way, the best way of doing it is to make the patient supine and get the axis on the other side, crossover. Then put the leg in a lateral decubitus position, and then get the popliteal axis. That's the best way to do it. It's all about patient comfort because the patient has to lie flat for a long time. So you have to take that into consideration when they're moving and everything. So
now, Dr. Wiley, we've crossed the lesion. Now what we're going to do is we're going to pull the sheath out and change over for a 6 French sheath. So we're going to go with the 6 French pinnacle destination with, again, end markers to let us know where we are. So Flora, please. So I'm going to, obviously the wire's up into the abdominal aorta, I hope, which it is, past our pigtail. We're going to come back down, okay? And now what I'm going to do is go on the AP view, right? And I'm going to walk this out, and I'm going to switch, and now I'm going to ask for my 5 French actually, you know what? We have the 50200 angioscope. We can use that. Why don't you go to my office and get a 50200 angioscope? Okay, go ahead.
So again, if you're trying to do with the 4 French from the popliteal,
keys in the
Dr. Wiley, we normally snare the wire. There are 2 ways of doing it. One, we have a snare, and one we have a catheter which can directly take the wire into the catheter. We try to snare it normally, and then just use it as a rail and work from the other side once you have an access.
So now you see I'm not going to lose wire access. I'm just going to keep my catheter here. Now I'm going to switch out for an 014 wire since I decided to use an angioscope by using another replacement catheter like the Aqua Tempo and with a stiff wire like the Grand Slam.
I just got a question here. Would you ever consider intervening through the radial axis?
Can you get
it's a long distance, but...
So the only problem with the radial axis, Dr. Wiley, is... I'll just answer for Dr. Krishnan because he's busy with the case, is the length of the catheter. If it's a short female, anybody who is more than 5'5", it's difficult to reach the equipment from the radial down to the mid SFA. You can only come on till the external iliac. You can't even reach to the proximal SFA.
So Jose, as you know, you and I share our feelings on this, and we've always been pretty much on the same page with certain things. And radial access for peripheral intervention is something that I've never found for anything useful other than really for renals or proximal iliacs. As you know, we've done carotids through the radial, we've done subclavians through the radial, we've done renals through the radial, and probably some iliacs through the radial. The majority of the time, though, the key is, please loop the wire nicely. The key is the radial is really not meant, in my opinion, for SFA or even below the knee interventions. First of all, like Dr. Karthik said, the equipment is really not there at this time, and I think maybe it will evolve. But at this stage, I think we use radial very, very selectively for cases such as this. And honestly, this is a demonstration case where we're really showing this. So you can see here, I asked Dr. Guja to loop the wire nicely because now you're going to be up in the aorta with an 014 wire. So this is where the discipline really needs to come in between you and your colleague who's doing the case. So now we're just going to go ahead. We're going to advance this into the aorta with a nice loop, like right there. I'm just going to make that loop, push it with a loop. Good, and leave it right there. That's fine with me. A little higher. That's good. That's perfect. That's fine. Yep, 50200. So Dr. Wiley, we're going to walk this out. Now we're going to use a 50200 balloon by the company Angioscope. It's the reason I chose to use a 200 balloon is because, as you know, it's a long lesion. I used a 5.0 here because I don't want to plaque shift or dissect into the common femoral, and especially into the profunda. So we're going to now really do the intervention in the next 30 minutes and show you how this case can be done within an hour. So we're going to go ahead now. And we're going to pull out this new balloon. There's a very limited market release at this time, and we're going to go ahead and do this. So mag up here, guys, for me. Let's do a roadmap. Inject. Okay, good. So you can see where we're going to be. There's no real clear dissection. And you can see, people could say, well, Prakash, why are you so far up the iliac that you're looking? And that's a good point, really. It's really a misgauge in doing this roadmap properly. So what I want to do here is just go ahead and just sort of come with the balloon just at the ostium, and then go ahead and open up the lesion. And then we're going to go ahead and either stent it or do something to it. Rail, please. Okay, careful. So the key here is really to watch the wire, like I said, in the aorta. So I got to trust Dr. Lascano here, make sure that everything is working well. And I'm sorry, a nurse practitioner Lascano, I keep calling everybody doctor. And what I want to do is go ahead up to the top. Now the 4 French channel that we've created with our catheter,
It's not moving.
it's not moving.
Yeah, it's not going forward.
It's not traversing, yep. Show me off-road map here, guys. Show me down below. So a lot of times, because of these cutting balloons are so large, off-road map, they may not traverse the CTO channel. So you can see here it's stuck in the channel. So walk this out. Give me a 4.0, 250, what is it called?
Nanocross.
No, not a nanocross. Yeah, you can give me a nanocross or an Armada Extreme.
So you're going to use a semi-compliant balloon.
Yeah, I'm just going to make a channel to get this up there. 4.0 long, Ricky, whatever you got. So I think, part of the equipment that we talked about, these are kind of the equipment challenges we face. And the challenge clearly here is the smaller, the equipment is really not very well made for peripheral interventions for these kind of challenging lesions. As you know, in the coronary, we're able to get things in where we need for them to go quite often. And I think the technology is improving. But however, in peripheral, I think we're still lagging a little bit behind with the equipment. I mean, I really, think it's a challenge for the companies because they really have to make things smaller for us, and making things smaller for us really helps us to get these difficult interventions done. Here's a lady who cannot have bypass, who's got really rest pain now with a single vessel runoff, very poor flow. So I think that helping this lady with this percutaneous technique really helps. But having the right equipment and maybe the right shaft length and the right stent length really will help us as well.
Prakash, in the worst case scenario that you weren't able to traverse that lesion with a semi-compliant balloon, would you consider laser?
Yeah, you could. I mean, I think the options here are obviously from the knee, from below, you can do anything you want. You can do laser atherectomy, you can do even directional atherectomy. If you want to put a 7 French sheath in, you can obviously put drug-coated stents, which is probably what we're going to use here versus regular stents. I'm not really certain. And then decide. The key here is I think important for people to consider is obviously patency is extremely important, but I think also cost effectiveness. Here we're probably going to need 2 or 3 stents to be able to get this case done. So, generally what we do is we go ahead and use a product that we can, that is, cost effective and yet has demonstrated some level of patency. We know the longer the stent, the poorer the patency. However, it is a symptom-limiting disease, and we would like for this lady to improve her symptoms. So these are all difficult choices. We're too high here. These are all difficult choices, and we'll talk about what we're going to do before we do it. A little bit of...
How long is this balloon?
It's 40200. Walk it back, Karthik.
Yeah.
So you can see I've really traversed deep into the common femoral area, and Dr. Gujas is going to bring it back and just kind of leave one dot. A little bit lower, please. Right, a little lower, right there. So I think I'm going to just inflate right at this spot here, because these balloons have a little bit of overhang. No te mueva, mama, lo siento. So you can see going up with the balloon slowly, and really just kind of trying to crack that lesion, She's okay. So now I just want to show you the balloon expansion, okay, all the way down to where we are. And you can see the proximal area of the balloon did not expand at this level. So go up a little higher here, Karthik.
Yeah.
There it is, a little more.
So where does it reconstitute, at 5 or where?
Probably a little less than 5.
Less than 5.
A little lower? A little higher? Okay, good. So you felt a pop there, and now we're just going to leave this up for a little while, and then we're going to talk about the choices for therapy. So really, you know, I think if you look at from the interventional toolbox, I think first and foremost, prolonged balloon angioplasty helps you to first of all understand the lesion and understand the morphology of what you're treating. So here with a prolonged balloon, I think we're going to get an adequate result with a 4mm balloon. Now we can go back in with a 5.0 angiosculpt and leave that up for a little while and also get a better expansion. And then the choice becomes is what's definitive therapy. So, I mean, the choices are simple. Well, you could do atherectomy. Directional would probably be the option here from the leg with a 7 French sheath. I'm not really excited going from the popliteal with a 7, so I ruled that out. Obviously, laser after you've ballooned with wasn't really our primary option here. Necessarily is not going to be something that's going to make a difference in terms of the patency, since we already have a 4mm lumen now, and we're going to end up with a 5. Lastly, it's going to be stenting. So the stenting can be either a covered stent or a bare metal stent or a drug-coated stent. So covered stents are options. I mean, I know yourself and my algorithm is very clear here that we don't like to use covered stents unless we have more than 2 vessel runoff in the foot, at least 2 vessel runoff or in the foot. 1 vessel is not something that we're really excited in using covered stents. The data obviously shows that you can, but our algorithm here and our experience here has shown that we're not going to do that.
And the reason?
The reason is just thrombosis. I think, people will argue. I know Dr. Saxon in California will argue with me about that. But clearly, in our experience, we've seen a slightly increased incidence of thrombosis in our hands when we have less than 2 vessel runoff in the foot. So the third option then becomes bare metal stenting or drug-coated stenting. And I guess this is where sort of the cost issue may come into play. Obviously, the longest drug-coated stent that's available is an 80mm stent, and the largest bare metal stent that's available is out to 200. So this is where I kind of defer to, I guess, everyone to talk to. My algorithm is, okay, the data with long drug-eluting stents is not randomized. Obviously, there's great registry data out to 3 or 4 years showing that it does work. However, it's registry, it's not randomized. The randomized trial obviously is done with shorter lesions up to using 80mm stents. So we know that crossing an in-stent restenosis is a lot easier from above or below, doesn't really matter. So I don't think if, God forbid, this crosses, it's going to be an issue. So I'm kind of leaning towards using a bare metal stent, but I could be talked out of it. So any thoughts from you first, and then Dr. Guja after?
Yeah, can I talk you out of it?
So you can talk me out of it.
Yes, I'm a firm proponent that the science has taken us to really consider drug-eluting stenting. Unfortunately, the cost is precipitous, and the length of the stents are not as long as we would like them to be. But in this case, that the patient had been limited with resting pain with only an SFA CTO, which in most instances a CTO of the SFA doesn't cause resting pain, I would be a little more aggressive. If she would have had claudication, perhaps I would have used a bare metal stent, but she was very limited with her symptoms based on this CTO. So I would be a little more aggressive and perhaps try to avoid instant restenosis.
Karthik, any choices?
I was going to go with the Zilver, but just because Dr. Wiley took the side of drug-eluting, I was going to go with the side of bare metal. I think just because of the length of the stent, I'm just thinking like, even with Zilver, if you go by data, more than 150 millimeter stent, even Zilver, I don't know how significant the patency rates for Zilver will be, because the length of the stent is always an issue. Once you cross 80 millimeter stents, any stent patency is compromised. That's been shown, that's been validated in all the studies. So I guess it really doesn't matter here. She's a first-time claudicant, so we can go with bare metal. I think it's okay. I mean, if she restenosis, then we can consider. It's just that we have to put 2, probably 4. 3. We have to put probably 3 drug-eluting stents, which is very, very we're talking about a lot of cost here involved.
So honestly, Jose, I agree with what you're saying, but I think in this particular case, I'm gonna defer on the bare metal arm, and I'm probably going to be criticized. So I can tell you that before we take this out, let's give a little dive from above just to see where the lesion ends. Go ahead. Die. Yep. So pull back a little bit. We're gonna have to balloon all this. Pull back, okay, pull back, okay, pull back, okay, go up there. So you can see it's a very long lesion. So what we're going to do is we're going to go ahead and balloon this area now and then go with the angioscope. So I guess what I was trying to say is that I think in this particular case, with her first attempt at a bare metal stent, with the data not really being clear in long lesions with Zilver, the cost being prohibitive, I think what we're going to do here is go with a bare metal stent. I'm just going to walk the sheet back a little bit. There you go. I'm just going to go with a bare metal stent after cutting this, prepping the vessel nicely. The only thing we haven't talked about is a slotted cell stent, okay? Now this is the one area where you could consider using it because you're doing a retrograde SFA CTO. So landing the stent at the ostium from the up and over approach with the Supera, which is now marketed by Vascular, may be difficult to do, but here from actually going from below down, it actually may be very good. So Supera clearly is a consideration here, but the issue is, the Supera's data is very, very good, in terms of with the popliteal, in terms of with the resistance to crush, and the patency data with the Superb trial has yet to, the registry has yet to be published. But I can tell you that the initial results are very, very exciting, and we also have that on hand here. So the question just becomes, what do you think? And I think, I'm going to give you a chance to talk about the actual slotted cell design here in this particular lesion.
I mean, you could always consider the Supera stent just because of that. It's not that calcified of a vessel that I would be.
Well, it is calcified proximally. So you saw the difficulty that we had. So what we're going so remember, if we're going to use a Supera stent here, we're going to have to really decide on the size of the vessel and do an initial vessel prep. The initial vessel prep becomes very important because the stent will start to elongate because it's really not a stent. It's a non-compressible stent. So what will happen is the elongation will occur if the vessel it's not sized properly. So normally we usually balloon a little bit more than 1-to-1 to really open up the vessel, either with a larger non-compliant balloon or with an angioscope, and then we'll go ahead and size it. So for instance, if this is a 6mm vessel, we will use a 5.5 Supera. If it's a 5mm vessel, 5.5 vessel, we'll use a 4.5 Supera. If it's longer, we'll use a larger Supera. So the point here is vessel prep and how you want to do it. So that's another option that we're going to do. So we're still not done here. So we're going to come down with this. Now we're going to get the 200mm sculpt ready.
Yeah, I think the only area of true severe calcification is in the ostium. The rest doesn't look that bad. I have a problem with using a Supera in a place that you want to be very precise with the placement.
Well, remember what I said. This is we flip the patient. So it's almost like you're placing in the pop and coming back towards the SFA. So therefore, your precise placement will be protected because the initial onset of the Supera is incredibly precise. So I really want to talk about what you think in terms of whether we should use the Supera here or not. Believe me, I'm flexible either way. I just want to bring it up for teaching purposes for the people at home who are watching, because this is a great obviously demonstration of a case. The thing with the Supera is obviously you want to make sure you deploy it in a way that's very, very nice, that you stack it properly, and you can also look at the diamonds and this and that and the other thing to see whether you're elongating the stent or not. So Karthik as always is flushing our sheath, making sure we don't have any clots, anything like that forming in the tip of our sheath. So now we're going to go with the angioscope again, a 5.0. So we're going up by 1, and we're going to go back into the vessel, okay? And then we're going to balloon from the ostium down. and this should allow the angioscope to pass. So before we put any stent, right now we're prepping the vessel. And I think that's important. I think we've learned from different trials, that good angioplasty is important as well as vessel prep is important. So that's what we're doing now is we're just prepping the vessel. So rail, please. Now you could argue, and a lot of my surgical friends who I'm dear friends with will say, hey, if it's a good balloon result, just leave it. And I think that's a reasonable argument. But however, it's not something that I believe in because the data clearly shows that balloon in this type of lesion is really inferior. Give me a little dye here, guys. So we've got to come way down here. So I'm going to come right about at that level. And I'm going to ask Dr. Guja to do it on the roadmap so I don't dissect my common femoral. Good. Okay, good. So I'm just maybe put the dot slightly up. But you know what, let's start here just so we don't go crazy. Go up here, please. So this is a 5 millimeter. What's nominal is? 6 atmospheres. And as we go up with the balloon, I want all of you to see that the balloon is expanding nicely, right, at the ostium. Right there you go. See, there's a little bit of overhang there. Yep. So I'm going to have to keep Dr. Guja to keep going up here to really get it. So you can imagine if the dot was truly inside the common femoral, you would really be angioplasting the common femoral quite well, and already we are. So you can see here is we're at nominal here, and we're going to show you down. So you can see the well-expanded nature of this lesion now. So it's truly probably a 5 millimeter vessel, and not so much a 6. So now we're just going to leave it up for a few minutes again, and then we're going to decide here. So again, so now since we've decided on bare metal, Dr. Wiley, do you think Supera versus a regular bare metal long stent?
I mean, point well taken that the difficulty of the Supera is the distal portion of the stent, the placement, the proximal portion should not be that complex. My forte is that I use Supera. The vessel is completely calcified, and I only see severe calcification in the proximal portion. The rest doesn't look that bad. And
you also have very good expansion with an angioscope than a regular balloon.
Yes.
So therefore, you're not really expecting I think if you look at our tibial data that you and I have looked at, recoil is going to occur, but the question is how significant is the recoil? So you can see here that the expansion was very even. Both sides of the stent have both expanded, likely meaning that we were intraluminal in our cross. So therefore, I think this may be a good opportunity to do either or, and I'm really open to it. So let's drop this now, then pull it back and do the bottom ballooning.
Dr. Guja, what's your opinion?
I think I will agree with you on this, Dr. Wiley.
Thank you.
Come down.
If the vessel is really, the whole vessel was calcified, I would have probably used a Supera because we are trying to get the ostium. I think precision, again, I think precision is probably not the most important.
A little bit higher.
But I think if the whole vessel was calcified, I would have definitely considered Supera. Again, we are not completely going across the adductor canal, so basically any stent here, any bare metal stent here would be actually okay. That's my opinion. So you're not at a flexion point, so.
Well, okay. I mean, you're right. All these points are there. So we're just we can see it expanded well down. We're up to nominal. So that's a beautiful rendition of a 200 millimeter, angiosculpt. I congratulate the company for listening to all of us and really getting this balloon out to us soon. And we're able to now utilize this in a live case, and I'm really happy about that. Walk it back, please. So now we're just going to fix the sheath as Dr. Guja walks this out. Great, it's walked out here. Don't advance your wire, please.
Yep.
Yep. So give me a 60200 bare metal stent, please. Okay, let's go low mag and take a nice DSA picture. So now we're going to take a nice DSA picture of the entire SFA. Ready?
DSA.
It is. Inject. So remember, you're obstructing flow down below with a 6 French sheath.
Sure.
So that's probably the reason why that looks so bad. I'm just going to pull my sheath back a little bit here, and then repeat another DSA shot. It won't come out. Ready? Inject. I just want to make sure we don't have anything below it that's causing an issue. And it's really not. It's just our it's competitive flow in our sheath. And you see there's a lesion right there that we need to cover. So we're probably going to need to use 2 stents here. So now I'm going to go ahead with my 60200, get my 035 supercore ready, guys. Huh? Dr. Wiley, there's a question of 7.0 versus 6.0 here. I think she's a small woman.
Yeah, probably a 6.0. Usually I reserve 7.0s for
no, first the stent.
Larger vessels. I think a 6.0 would be okay.
Can I have the stent, please?
60200.
So Prakash, I'd like to dive into a technical point, and is when you place your stent in the ostium of that SFA, are you going to be using the upper border of the SFA or the lower border of the SFA for placement in order for you not to miss the ostium?
To me, I think covering a little bit into the common femoral is good in this particular reason, just because you have such a diffuse plaque at the level of the SFA, and you clearly have caused a little bit of plaque dissection in the common femoral. So I'm not as particular with this as I am with the renal or the subclavians in terms of stent placement. So therefore, I would tell you that here, in my opinion, it doesn't matter. Walk this out. Put the supercore up, please. Walk out the wire.
So if you want,
walk out the wire.
If you're okay with
you're way up.
having a couple of strands inside of the common femoral, you
actually
probably
okay
use the
with
lower
that.
border.
I know that people will not agree with me. I just, I know that there are extremely experienced interventionalists who I respect very much, who are much senior to me in the field, who have covered the profunda and have had no problems with covering the profunda, and I think the profunda does well. Obviously, it's not an ideal thing that you or I would ever promote, or anybody would promote, but I think the bottom line is you want to get the case done in an effective manner that's going to help the patient. So in this particular case, I think if we go ahead and have to cover a little bit into the profunda, I think you're going to be fine, although in this particular case, I don't think we're going to need to.
So essentially, if we use the lower border, we probably will not cover much of the profunda, and at the same time, we're inside of the common femoral, both in the upper and lower border.
So that's where your high mag really is going to help, right? So right now, what we're going to do is we're going to give a little roadmap, right? And I think, again, this is a very good teaching case. So we're just going to give a little injection now. So this is going to tell us where the common femoral is. Now he's going to come back down. Now you notice how you see it's impossible to cover the entire SFA ostium without covering partially the common femoral. You see how the profunda takes off?
Which is okay.
So the point is that's kind of where you're going to have to deploy it, maybe a little bit lower, but you don't want to miss this ostium. So I think, if you flare it there and then adjust it and then decide, that's okay. And I think this is where the position of what you and Dr. Guja talked about works out. So obviously this is Dr. Guja's first stent live, so a lot of pressure. So I want all of you at home to know that. But so you can see here that he's pulling it back there, which is common on all of us. We've all done it. So I'm going to adjust it a little bit for him. I'm going to push it back up, right? And I'm going to allow him to flare it. And this is where I want everybody at home not to worry about flaring it. You see how stop there, Karthik. You see how the markers are there now, Dr. Wiley? See, at this stage, you've got the stent opening. So when you've got the stent opening, now you can adjust and place it properly. See, if you try to just hit it right at the ostium from the beginning, what's going to happen is that you may either fall short or jump forward. So 2 things you need to understand. First is that particular thing that you're seeing. Second is, once you place it, do not elongate it. These stents have to be deployed properly in order to actually go ahead and maintain their patency. So very interesting. If you look at some of the data with stenting, and you know that when you elongate a stent, it does not do quite as well. So therefore here, you're more prone to stress fractures, et cetera, et cetera. So it's very important to follow proper design in placing this proper. How can you say not design? Proper. What's the word I'm looking for? Proper procedure in deploying a stent. Okay. So go ahead. Our technique. So Dr. Guja is going to now just go ahead and try to flare it here a little bit higher. A little bit higher, you're going to miss it. There you go. Okay, now you see he's got control. So now he can pull back or further, and I'm going to leave it to you, Dr. Wiley. What do you think here? You'll pull back?
I will pull back.
Yes. Slightly? Okay. How's that, Dr. Wiley?
We'll pull back just slightly more.
Actually, I'm happy about that. I'm going to leave it here. Yep. Okay, so you know what? Let's stop here. I'm going to give a little dive for the folks at home and do a little bit different views here. So a little down. Okay. So now you remember you're in a foreshortened view. The profunda is above. I'm just letting you know how it's sitting in the common femoral.
You want to do another ipsilateral view with?
Yep. Now we're going really wide to really show you where we are.
Because you still have a chance of pulling.
We can still adjust this stent.
Correct.
How do you like that now?
I like it very much.
I do too. Let's deploy it. Don't pull it back now. That's the key. Excellent. Don't worry about that profunda. You're fine. Good. Now we're just going to watch it here because we know distally it doesn't really matter to us. We're just going to go ahead and deploy it. I just want to make sure now it really shouldn't move unless Dr. Guja pulls it, which I know he won't. So you can see here.
Well, we're going to see now in the next picture.
Right. So let's walk this out, guys. Yeah, his first stand. We'll give him a good hand here. Right. Live. He's doing a great job.
So let's see the picture before we give a clap.
Yes, sir. Yes.
Dr. Wiley, very, very skeptical, as usual.
So Ray, you want to go to 4 and see what's going on? Okay. Okay, ready? DSA? Let's go DSA here.
I think he deserves a round of applause.
See, but see, Jose, how part of the stent is still not perfect, you see?
It's still okay.
Yeah,
I think the bottom border of the SFA was covered. I just think you need one balloon inflation right at the ostium and it'll be perfect.
I totally agree.
For me, it's very important to preserve the profunda regardless of what other people may say.
Okay, that's great. I don't think the profunda will go down here, though.
No, absolutely not.
All right, good. Let's look distally just to make sure we cover the distal border here. Ready? DSA, let me just go a little lower. I think we had to put another stent.
So you only have 1 or 2 stents just protruding into the common femoral, which is very fine.
So we ballooned past 5, so we should put another stent here. So the question is, what size you want to? You want to put a 50, 60, 60, or what do you want to do?
Gosh, it doesn't look that bad. I'm looking at the distal.
We know that this area has been traumatized and ballooned. You know, I don't want to. I don't want to put a stent. I don't want to not put a stent here after doing all this hard work. So let's go ahead and put a 6080, please. 80 or 60? I think 80, right? 6080. So at this stage, Dr. Wiley, I mean, we're pretty much done with the case. You know, I just want to, you know, we're on time. It's 1 hour, so let me just show the sequence of events. So what we've done is we've now stented this the proximal and distal, and now what we're going to do is we're going to go ahead and place another stent distally. Once we place the stent distally, we're going to go with a 60200 non-compliant balloon, and then with the 60200 non-compliant balloon, we're going to balloon the entire segment. Okay. Once we balloon it, we're going to take our runoff as well as our final picture, and then we'll show it to you in a second. So we're just going to go ahead and do it right now, so you can just watch. We're going to be a little bit quick because I know that we're about an hour into it, and for our audience, we want to really let them go back to their practices. So rail, please, Flora. Yep, perfect. Ooh.
What are you going to do with the sheath in the?
Too long.
What are you going to do with the sheath in the popliteal?
Yep. Go ahead. We're going to deploy this. We're just going to pull it in hold pressure, Jose.
Is there any data on closure devices in a case like this?
I mean, there's no data that I'm aware of. I don't know if you're aware of anything like that. That's perfect.
I'm not.
Sheath came out.
Yeah.
Okay.
I'll give you a dilator.
Okay, go. Okay. So the sheath came out. One of the things you got to be careful with when this happens.
It's close to the sheath. Okay. The other wire.
The wire's not out yet. You're not out.
You said the sheath is out?
Yep.
Yeah, we're going to. It's too close to the.
Give me a new 6 French sheath, please.
Short sheath, please.
So now we're just going to go ahead and exchange this out. I think that's part of what we got to do anyway.
Yeah.
So it just saved us a little bit of time here. And then through the regular 6 French short, we're going to put a balloon. So you can see I have complete hemostasis with just a little bit of pressure. So that's exactly how we're going to hold this. So this way it doesn't bleed into the pop. So So give me a 60200 non-compliant balloon, please. Yep.
That's one of the only problems, I mean, at least as a fellow, I have felt, Dr. Wiley, because, I mean, I think if the fellows are watching it, the problem will be just holding the sheath is again important. So usually that's the part of the fellow training. So I usually hold it with two fingers on top of the artery.
60200, guys.
And then get complete hemostasis on the popliteal. I felt that was what was recommended in.
Well, it's sort of like you're holding an antegrade sheath. You want to hold above and below as the actual hole, you know.
Top of the hole.
We try to hold above, below, and partially at the hole where we enter. So this way you don't have any retrograde bleeding. So I think this way it'll be fine. So this is a 60200 Dorado to balloon it out.
Huh? Can you 60200?
No, you gave me a 20, guys. You gave me a 20. I need a long.
200.
So again, you know, it's important to have good equipment, and obviously this is not the proper balloon.
We just missed a 0.
Yep. A very important 0.
Yeah.
Okay, so this is a really truly a non-compliant balloon, a phenomenal balloon, and you know, we feel that it really needs to work on an 035 wire rather than an 014 wire to cross stent struts. But you know, if you need something expanded, this will expand it. You know, it's one of those things where you don't have to worry about this expanding, so you actually have to worry about over-expanding at times. Rail, please. So we're just going to go back above here and just show you the ostium. You know, and what we're going to do,
Way up.
I went up, right?
Yeah.
So what we're going to do is right about here, I'm just going to go up. Again, you're going to see a lot of overhang, guys, which I think that's why you sometimes have to go up with the balloon and adjust the balloon. Go up, Ray. Slowly.
Go 6, only 6. Just go slowly.
3,
4, done.
4, 5,
6 also.
5.
Okay. 6 is what normal.
Go to 6. Okay, very good.
What's nominal in this balloon?
6.
6.
Let's see it down, how much more we have to do. Wonderful. Down.
This is
I'm just going to advance a little bit here.
this is a 6.0 balloon, right?
6-0 balloon. Negative, guys.
Yeah.
Just going to advance it. Okay, go up here, please. I'm going to make sure we really flare the ostium since we were very, very close to the common femoral. There we go. Let's go to 6. Don't worry about it.
You should have gotten the upper border of the SFA ostium.
Yes, senora. Down. And then walk it back now below. Let me just walk the sheath back now. Negative, guys. It's not down yet.
Yeah. Doing it. Yeah.
Okay, it's not down yet. Okay, walk it back to the distal border now. So the overhang of the balloon is extremely important. I'm fixing the sheath here as Dr. Guja comes back. A little bit more. A little bit more right there. Go up there. Six. Lo siento, mama. And you can see beautifully expanded all the way up, all the way down. Down, guys. So we're going to let this come down. Dr. Wiley, you got to get double negative.
It's been almost an hour. We're going to get a post-angioplasty picture.
You got to come down again. So it takes a while for this balloon to come down. So I think one of the things, so you can see here, these kind of complex cases can be done in a short period of time. You know. Okay, so let's go ahead and get a low mag picture here. It's actually quite good. Take the shot right here. See, now we're able to get the whole stent open, Jose?
Yep, looks good.
So, and it's like well expanded. And we're just gonna look proximally to make sure proximal we're okay. Mag up here, guys. Okay, ready? Beauty.
Nice.
We're
This
done.
is very good.
So, you know, so we'll take the runoff picture, which I don't think we'll have a problem with, and I think this is a great teaching case. So, in summary, I'll go over this in my final talk when we're done. So, we talked about the access, we talked about where how you approach these patients, the anticoagulation, the actual cross of the actual lesion, and then the final stenting and the choices that we have. You know, it's 9:05 in basically an hour. We were able to get this case done from skin to skin, and Dr. Guja will now, take care of the final pictures. I want to thank Elizabeth, Ricky. I want to thank obviously our nurse practitioner, Ray, and Dr. Guja, and yourself, Dr. Wiley. And I invite the entire audience to obviously come to our symposium in June 10th, 11th, and 12th, and 13th. But the Complex Coronary, Valvular, and Vascular Symposium. And we look forward to our next presentation, which is going to be a week ahead next year, which is the week after the symposium in June. So I really appreciate you guys watching. Thank you.
You mean next month?
Next month. Thanks again.